So I do want to thank everyone for joining us. This is really a first of its kind webinar, one where the CGD Association has joined with 3 other primary immune deficiency groups, and we're just thrilled that we've been able to do this. This webinar is an opportunity for us to talk in a real way about family planning and primary immune deficiency. We've invited a reproductive specialist and members of top primary immune deficiency groups to learn the latest on family planning, genetic testing, and fertility. So this is really an important opportunity to learn the latest and gain important insights on how to make decisions for yourself or your family. And we really don't have any judgment here. Every decision that you make, any decision that you make, is yours to make alone. There are no right or wrong answers. But at the CGD Association and all of our organizations, we truly believe that knowledge is power. The more you know, the decisions you make, you'll feel more confident in those decisions. And I'm also very pleased to introduce our other groups that are here. I guess I should mention who I am. My name is Felicia Morton. I am the Executive Director of the CGD Association of America. And we are committed to raising awareness for CGD. The way that we do that is by advocating for patients and X-linked, or all carriers of CGD. And we are committed to providing news and information to help our patients and carriers make decisions, and also advancing research. And I'm also the mother of a son who was diagnosed with CGD in 2012 when he was 5 months old. He has since had a successful bone marrow transplant at the age of 4. And I'm a carrier, and my mother is also a carrier. And the other co-hosts who are with us are Heather Smith. She's the president and co-founder of Skid Angels for Life Foundation. Samantha Yanger, executive director with Scott Aldrich Foundation, and Akiba Zablocki, MPH, president of Hyper IgM Foundation. And I'm so grateful to all of you for helping to organize this event. All of the hard work that we have done has come to fruition today to just ensure that we can get together and share this moment and learn it together. It's so important. And so without further ado, I wanted to introduce our first panelist. Her name is Tiffany Hill. She's a board member of the Hyper IgM Foundation and a parent to 2 boys with hyper IgM, as well as unaffected twins that were born with IVF PGD. Her sons, Oliver and Liam, underwent bone marrow transplants at a very young age. While Oliver is now thriving, in 2014, unfortunately, Liam did pass away from his transplant. After everything that Tiffany and her husband endured, she wants to ensure that hyper IgM families all around the world have a community where they feel supported, have access to a wealth of knowledge, and can continue to push for a better cure and better treatment options for hyper IgM. So I am just thrilled to invite you and introduce you today. Tiffany, I understand you're going to be giving a presentation, and we're going to turn it over to Tiffany.
Thanks, Felicia. Hi, everyone. I'm Tiffany. Let me see if I can get my slides up here. Like she said, I am a board member now of the Hyper IgM Foundation due to, obviously, my first 2 born sons had hyper IgM. I'll share our story and kind of briefly. It can take a while, but I'll share what I have here. Let me get this here. Here we go. Hopefully everybody can see that. Me and my husband, Joshua, we've been together for almost 20 years now. And when we decided to have kids, our firstborn was Oliver, and he was born in 2013. And when he was healthy, everything was good. We have no family history of any issues or hyper IgM. When he was about 6 months old, he got really lethargic and kind of just real quiet, not himself. So we took him to the pediatrician and followed up for a couple of days, and they couldn't really figure out what was going on. They did blood work, and then they did a chest x-ray, and they figured out that he had really bad pneumonia. And when we were in the pediatrician's office, his oxygen stats started dropping down to like 37%, and he was breathing really heavily, like 80 to 90 breaths per minute. So they put him in an ambulance, took him to the ICU, or the pediatric ICU, PICU, and they ended up intubating him, and he stayed intubated for a little over almost a month and a half. It progressed and got even worse. They really didn't know what was going on, and his on the ventilator, it got worse and worse to where he had to be put on an oscillator machine, and they life flighted him to Children's Hospital in Arkansas. So we were living in Louisiana at the time. There we had an amazing immunologist that once they were able to get his settings down a little bit, they were able to do a biopsy of his lungs, and they figured out that it was PCP pneumonia, which is usually indicative to some type of immune deficiency. And they started him on Bactrim and all that stuff. And so he made a pretty quick turnaround and was able to come off the ventilator, and we were able to take him home. And we found out there at the hospital that he had hyper IgM, which was, it's super rare, 1 in a million, and we knew nothing about it. Luckily, around that time, we were able to link up with Akiva and Amanda, and they were starting, I know that there's kind of a hyper IgM group or whatnot, but they really moved that forward. And we talked with them. They were really helpful. Their son Idan was going through that prior to Oliver getting sick. So kind of fast forward, the only cure for it was a bone marrow transplant. So we went through chemo and a transplant when he was about a year old. And right before then, we're getting genetic testing to find out. I actually found out, contrary to not supposed to be able to get pregnant, I got pregnant again. And unexpectedly, right before Oliver's transplant. So during his transplant, I remained pregnant. We thought about doing an amniocentesis to see if the baby that I had, because I also found out, sorry, I skipped that. I found out that I was a carrier about the same time, if not right after I found out I was pregnant. So we wanted to see if we could find out if the baby was a boy or a girl. Boys have a higher chance, obviously, of being affected because it's X-linked. And but the doctor just encouraged us that if it wouldn't change the course of the pregnancy, go ahead and carry out the pregnancy. We would test him when he was born. So Liam was born in April, actually, of 2015. And a couple of months after that, we got him tested. And unfortunately, he had hyper IgM syndrome too. So during that whole time, Oliver was still going through his transplant. We had some complications. He got CMV. We were admitted for several months, actually, and we had to move away from our home during the whole time. But the transplant itself went pretty well. He contracted CMV, and we were inpatient for a while. This was Oliver when he was in the hospital. This middle one was when he was admitted when he was 6 months, and when he was sitting up in the chair when we were almost close to going home. And his transplant's the one all the way over to the right, I think, on your screen. This was Liam when he was born in 2015. And we found out pretty quick, like I said, that he had hyper IgM and that he would also have to go through chemo and a transplant in hopes of a cure. And this was Liam going through transplant. You can kind of see where he's sitting with me, that's actual transplant. And then we were sitting outside in like a little tent in the middle after his transplant. You can kind of see he loses some weight, and then he had gained a lot of weight here, the picture with my husband. And he actually, in hindsight, finding out after he passed that they did a autopsy and found out that he contracted a fungal infection when he was inpatient, and he passed away. He was about 13 months in 2016. Sorry. So after he passed away, we decided after a couple of years that we actually wanted to go through IVF and PGD to kind of obviously make sure that this wasn't something we had to go through again and our kids didn't have to go through, that if we had a girl, that she wouldn't have to go through all of this. It's very personal choice, obviously. But for us and everything that we had gone through, we really couldn't take that chance personally. So we decided to go through IVF. We are very fortunate that our families were willing to help us financially go through that. We also had to take loans. As you know, IVF can be very pricey, and sometimes it's not really an option. So we were very fortunate that we had supportive family and the means to be able to do that. We went through in 2016, 17. It took us about a year and a half. We went through our first round, and we had only one boy that was completely unaffected. So through IVF and PGD, just to kind of give a brief thing, they can actually go through, and we did the whole testing, like they test for all these chromosomal abnormalities. They can test if they are affected, unaffected. We also knew gender and all of this stuff. So we went through the first transfer. We only had one unaffected male embryo the first round, and I ended up having a miscarriage. So we decided to try one more time, and we did a second round, and we were able to have 2 female unaffected non-carrier embryos and 1 unaffected male. So as my husband likes to say, he wanted to just put in 1 and I wanted to put in 2, just because we wanted to make sure we didn't, at least 1 would take the second time. So we compromised and we put in 2. And we now have our twins that are Lily and Elijah. They'll be 4 actually in August, and neither one of them are affected. Neither one of them, she's not a carrier. We don't have to worry about any of that. And they're twins have been very challenging, but it's been very fun. And we're obviously very grateful to not have to worry about that aspect of it, having gone through years with our first 2 boys and their transplants. Oliver still follows up every single year with the Survivors Clinic, and he is doing great. He'll be 9 in September. So in most respects, you'd never, ever be able to tell what he's gone through. And he doesn't remember, although we have lots of pictures and we talk about it. It's obviously a big part of our life, as well as Liam. So with IVF and PGD, I know this is kind of like a long story, but it was huge for us to have that option, to be able to kind of remove that for, issues for our kids going forward. I know it's not always an option, like I said, but for us, it was a lot. IVF was an emotional roller coaster, as many people will refer to. The cost can be up there, but for us, it was, in a sense, priceless, with obviously having access to means to be able to do it. And we had that support, but we were able to have kids that and kind of complete our family, that we don't have to worry about that. And I know it's very personal, and the embryos and stuff, that after that maybe are affected or that are still there, we kind of had a pull to, we had an unaffected female embryo there that we kind of felt like we were done having kids, but it was there, and we went through all these things. And just so people know, it's always an option. We were able to donate to really good friends that also couldn't have children. So you always have that option. There's, I know that this is dedicated to IVF and PGD, and there's other things people will discuss as well, and other options. But for us, IVF was very successful, while it was still difficult with all the injections and the things that you need to go through. It was well worth it. It's just, it is an emotional roller coaster and quite a journey. But anyway, that's kind of my story. Hopefully that's informative. I really appreciate you guys asking me to be here, and I love sharing our story. And everything that me and my husband have gone through. So
Thank you so much, Tiffany. Thank
yeah,
you.
thanks, Alicia.
Wow, your children are so beautiful. I just am grateful for the opportunity to learn about your story. I felt like I was on an emotional roller coaster with your story, hearing about what you've gone through and how things are now, and seeing the smiles in the pictures, seeing the beautiful faces of your children. It just makes me feel so happy, and it kind of reminds me of what this weekend, this time together is about. It ultimately it's about mothers in a way, and all the work that mothers do, all the things that we go through as moms. Not to say that dads aren't, a big part of it, but this is the day before Mother's Day, and one thing I wanted to mention also is that we're going to be giving away special things and to honor mothers and all the work that and all the things that a lot of us in this community have been through. So if anyone in the chat would like to have the opportunity to be a part of that, we're going to be taking some names at the end of this conference, at the end of this webinar, actually. So I just wanted to let people know that. And also, so people will just need to write your name and then your community, where your PI, where you're from. And then we will, at the end, we'll have this opportunity to have a drawing from each group: Hyper IgM, CGD, SCID, and WAS. And I wanted to make sure people knew that. And Tiffany, there are so many questions in my mind about what you went through. There are many things I didn't know. And for example, I didn't know that you could donate the embryo to another family that you might know. And there are just, this is why we do this. There's so much that we learn from each other. It's so important as I think about, my daughter, as I think about all of our daughters, I think about all of our parents out there and our children, and what the other piece of it is my son. These are all questions that we're going to continue to have, for generations. And there was really no more important question in some ways. So I'm just so grateful for you for that time that you gave us. And if anyone has questions for Tiffany, you can put them in the chat, and we will have a Q&A at the end of our webinar after Dr. Rieg speaks, who is our reproductive specialist, who's going to be joining us after we hear from our other panelists. And so moving ahead to our next panelist is Dawn Adams. Dawn is a member of the CGD community. She is the mother of 3 grown children. She had 2 sons go through a successful bone marrow transplant. And she was an inspiration to me because she went through that before I went through my stem cell transplant with my son. And so I will always be grateful to her for helping lead the way for my family. She also went on to use an innovative technique to have a carrier daughter. It's called, well, she had a daughter, and so it's called sorting technique to have a daughter. And as we know in the CGD community, because it's an X-linked condition, and in general, that the majority of us anyway have X-linked CGD. To think about having a daughter as another way to approach family planning. So Dawn, my good old friend from way back when, I wanted to turn this over to you. And if you could please tell us about your CGD journey and how you came to find out about the sorting technique and what your experience was with that form of family planning.
Yes. Well, first of all, I appreciate you asking me to be here, and I'm looking forward to learning a lot since I haven't been pregnant since 2000, so it's been a while. My name's Dawn, and we've been part of the CGD family for almost 30 years now. My eldest is 26, and way back whenever he was 4, and I was rocking a 1-year-old here in South Georgia, we don't have too many huge medical facilities around and specialists here in rural South Georgia, but we do have TV. And I was watching Oprah and I saw a doctor on from Microsort, and they were talking about gender selection. And after having my 2 affected sons who were struggling with multiple infections from CGD, I was intrigued. And I'm a researcher throughout that journey with CGD. So the next day I started researching Microsort. And a couple of days later, I was on the phone having a consult with Microsort because, the doctors that my sons went to at NIH were talking bone marrow transplant and gene therapy and stem cell transplants. And, within the next 10 years, they're going to be cured and this kind of stuff. So I was thinking, when a sibling might be a match for one of these boys. So a few months later, I was making the trek to Virginia where Microsort labs were. And my then husband, and I started the process. And the process was not implantation or IVF and PGD. I had to write that down because that's new to me. PGD. It was just insemination. And it was insemination just by analyzing sperm and boosting my egg count through hormones just for like a week stay, monitoring my ovulation and checking my peak time to be releasing eggs and so forth. And they took this sperm sample, and girl sperm are a little bit larger than boy sperm. So they dye this sperm with a fluorescent stain and they spin it out or wash it. And the girl sperm glow, or I don't know what the term is. They burn more brightly. So they were able to separate girl sperm from boy sperm. And then they inseminated me with more girl sperm. And so I guess that was the sperm separation. And so then they obtained and washed and prepared the sperm and then inseminated me with more girl sperm. And that increased my chances of having a girl from 50% to a little over 90%. And that ours was a successful treatment, or successful the first time. So anyway, I was able to have a girl the very first time with that increased chance. And so we got our girl, and she was a carrier. She is a carrier. She's 21 today. And after researching this, when I talked to Felicia, was just speaking with her on the phone and just telling her about our journey, I researched Microsort, and I found out that they are not FDA approved. So I did want to read this. Whenever I went, they were in a clinical trial back then to search for FDA approval, and it was discontinued due to economic reasons because now they are no longer performed in the United States. But the FDA recognizes that Microsort is safe and effective, but discontinued because the method for family balance, but discontinued the use of the method for family balance at not finding public health benefits for it. But they are still doing this in other countries under the Microsort name, the same technique, and they still freeze it in these labs. One is in Mexico, and send it back to the United States for IVF and this PGD. So they're still using the same labs for these techniques here in the United States. They still are doing the IUI, the insemination, there in Mexico and 3 other labs in the country, around the world. So this is a much less more cost effective. It's like 3,000 to 5,000 versus the high cost of the implantation and the PGD. So I just wanted to mention it in case it might be an option for other people.
Right,
It's
and
still the same percentage, 91 to 93% increased chance of female.
right, and so when you had told me about this technique, I wanted to explore it a little bit more because it's not as well known. And I did talk to Dr. Reeg about it, who's going to be joining us about on this call later, and he can talk a little bit more about it as well, because it is a little bit, as you acknowledge, it's not as common in this country. It's something you hear about in other countries, and perhaps unfortunately not for the reasons why our communities would be looking into it. So these are different options available, and that's why we're talking about it. And one of the things also is the percentage of probability that you will have a girl. It sounds like, you know, there's still a 10% chance that you could have a male child, and so there are some questions about that. And then there are also, from me doing a little bit more research, it sounds like you were very fortunate that you were able, that it took the first time, correct? Because that might not always be the case. Did they tell you that it might not take the first time when you were preparing?
They did. They said it would be the same as just a natural pregnancy. So a lot of factors come into play, your fertility, the amount of sperm, and so forth. So they would discuss that. And you know, I didn't research it right now like I would as if I was going through the procedure. So somebody would definitely need to look at all those factors and talk with their own physicians about that. Mm-hmm.
Absolutely. Absolutely. And we always say that we're here to provide information, but definitely talk to your doctors and find out things firsthand from your doctors. But we do educate our communities and give our communities as much as we know from our experiences, and your experience has been very interesting and beautiful, because I've seen pictures of your 3 gorgeous children, and whenever I am able to catch a glimpse of them on Facebook, I'm filled with joy because they're gorgeous.
Thank you, Felicia.
Thank you so much, and happy Mother's Day to you as well. And so turning to our next family, we have the Harrises. We have Robert and Cindy Harris. They are 2 teachers living on the Gold Coast of Australia with their 3 children. Their oldest son was diagnosed with Scott-Aldrich syndrome, and the family embarked on a long PGD IVF journey over 2 years to find a 10 out of 10 tissue match for their son. Robert has since written a book about having their son. It's called Saving Ryven, which details the experience. Rob and Cindy Harris, thank you so much for joining us. And there is your book. We are so pleased to see it. If you could give us information about it, I would love to order it, and would really be interested in reading your experience. And of course, we are really thrilled to have you and to hear more about your journey and how you have experienced.
Thank you.
Scott-Aldrich, and also, pardon?
I was just seeing if you could hear us.
I can hear you. Just wanted to say thank you for being here, and excited to hear your journey about with Scott-Aldrich and your family planning journey as well. Thank you.
Thanks. All right. Thank you. Hi, we're from Australia, and it's the middle of the night for us, so excuse us if we make any mistakes. It's probably because we're half asleep still. So 9 years ago, our son Ryven was born with Scott-Aldrich, and he became really sick at about 3 to 6 months. You know, it was a bit of touch and go in the hospital when he was young, and basically we were told then that bone marrow transplant was our only way out of this. So obviously going to the worldwide registry, trying to find a match for his transplant, the best we could come up with was an 8 out of 10. And speaking to the doctors here, Rob and I were just not comfortable with that. And knowing that we wanted other siblings anyway, or other children, we decided to go down the IVF route. Now, when we did it, we wanted two specific things. We wanted to make sure any further children we brought into the world didn't have Wiskott-Aldrich syndrome. And we also specifically wanted his sibling to be a match for him, so that when he went into transplant, we could give him the best possible chance. Now, it's not cheap, it's not easy. We were just lucky to have such a wonderful community around us. And being teachers, some parents from our school rang us and said, "You worry about your child, we'll do the rest." And this beautiful community fundraised close on $100,000 for us to go through this journey, and we pretty much used all of that. So it was a very, very expensive commitment that we made, but luckily for us, we had the community behind us and they did everything for us. We went through 6 rounds, and it was pretty heartbreaking. Every round you'd start with 12 eggs, it would be fizzled down to 6, then it'd be fizzled down to another 2, and then you'd get the results after growing all these embryos, and they'd all have Wiskott-Aldrich syndrome. Or we'd get to the end and then be like, okay, well, you've got 2 great ones, but they're not matches for your son. And we were literally right at the end of our tether and going, oh my God, I don't know how much longer we can do this for. And luckily for us, we did eventually find that match. And little Luca was born probably about 2.5 years after his brother. And ironically enough, Ryvan ended up being fairly well. And when it came down to transplant time, we actually chose not to go forward with the transplant at the moment, just because Ryvan's health at the time was really good. Now, the only reason I mention that is because having done the IVF journey and having a sibling match in the house with us gives us that privilege, the privilege of time. If Ryvan's health does start to deteriorate again, we have the cord blood, it's sitting there, it's for no one else, it's for our son only. We also have his brother if he needs some more, if he needs a backup donor. And his brother, he's quite aware of that as well. He's like, yep, I'll help my brother out, that's all good. So for us, it's brought us peace of mind, and it's also brought us time, I think, to give Ryvan the best chance of his life and to make the best decisions for him. So we can wait and see what science has to share if gene therapy would be better, which wasn't an option for us 10 years ago, but it could be a possibility for us in a few years' time. Robert, it was a big journey for us, and I think even though it's a big thing for mothers, I think fathers it's a huge thing for too, and hence the reason Robert also wrote the book about our journey. But he also wants to share some of his experiences, I think.
Yeah, it became just a bit of an insurance plan in the end there. We were in a very volatile position when Ryvan was discharged from hospital after spending close to 2 months in hospital. The options for us, because we didn't have a match, was quite frightening. So we took the avenue of trying to get an insurance plan. That's why we went down the PGD IVF route, and fortunately we were very, very, very lucky. But people need to remind themselves it is a game of chance. There's no guarantees that you're going to find that embryo. It is a game of chance, and as we said, look, it took close to 2 years to find the embryo match, and through those times it was extremely challenging times. But it was also really important to have small wins as well. And we didn't base the success of it whether we did find an embryo. So as we said, 6 rounds, we needed to find small wins in each of those rounds to stay positive. And we would celebrate those wins as well. You know, we might go out for a nice meal or something like that, just to stay positive and have a positive frame of mind, and keep on reminding ourselves that we are getting closer. Even though the journey was extremely long, we needed to keep on reminding ourselves, well, we're going to get there. We are going to get there. Yes, again, it might not have been a successful round, but we wanted to take small wins out of that particular round, and you know, just stay really, really positive. I suppose, as Cindy said, it's extremely challenging for both of us, and it's really hard for the dads. But the most important thing for the father is to really stay strong and try and be that rock of support for the mother, because obviously going through those rounds, the hormones for the mother are definitely ups and downs, and you need to make sure that you're staying positive. And we like to write a lot of quotes around the house, so we've got a room full of sticky notes, and that's where we'll write our small wins down and remind ourselves of the end goal. But there are plenty of challenges, and I suppose one other challenge was having so many embryos on ice. Once we did find the match for little Luca, it did take us. We just put it to the back burner all the time. We kept getting emails from our IVF company that we did have a number of embryos on ice, but we just kept them putting on the back burner. It took us probably 18 months for us to sort of look at each other and say, hey, what are we going to do here? So we did decide to deposit them in the end after about 18 months, which was a tough decision, but something that we needed to make a strong mutual decision together, and look back with no regrets. But I suppose that's a little bit about our journey. But we definitely went down the IVF route because we were stuck, we were frightened, we were scared about Robin's health, we were desperate, and we couldn't really see any viable options to save him. So hence the reason why I wrote the book, but obviously Cindy's had big input in the book as well. But PGD has been absolutely incredible for our family. It's been the insurance plan that we wanted, and even though we haven't gone down the bone marrow transplant path, we have that in the back of our minds, which is definitely it's been great for our positive mindset as well. Having a son born with Wiskott-Eldridge syndrome, not knowing what's around the next corner for him.
Thank you so much. And Rob, I want to say firstly that my husband as well wrote a book about our journey. And so we do want to acknowledge dads. We do want to recognize everything that they do, because it's very touching to me how you've said to be that rock, to be that support as we go through this. And I'm really inspired by your story, and I look forward to reading your book, because dads often suffer so silently as they're going through this as well. And we want to really recognize that. And what touched me also about your story is that this reference that you make as an insurance policy, knowing that the donor sample, knowing that you have the cord blood, that you have this insurance policy for your son. It sounds like that's an incredible relief to you.
Yeah, it sure is.
Definitely.
Yeah.
And that's something we struggled also to find a donor, and looked into this ourselves. And I'm learning so much from your experience and how to go through it. You know, the emotional steps you have to take, the logical steps, the financial steps, and to hear that it was that you raised $100,000 and you used almost all of it. You know, it is daunting for families to think about that too, and that it sounds like you had a support system that did that for you, and that's a true blessing.
I was just saying that you'd be blown away by how many people there are in your communities that also love to help and would just cherish an opportunity like this to actually help out. even whether they don't even know you, they'd be so interested in these stories, and just people just love to help out.
Yeah, that's what we found. We also had a fundraiser for our son's transplant, and I was just blown away that people supported us, people we didn't know, people just wanted to do something. And so that's a really key message too, that however families decide to move forward, that there's support out there for us. We're not alone. Carolyn, you are the mother of a daughter diagnosed with ADA SCID and an unaffected son resulting from IVF and PGD. You've worked as a stay-at-home mom for several years, and after your daughter was born, you are now a paraprofessional at an elementary school. And Carolyn, I am so pleased that you could join us and share your family planning story. I look forward to getting to know you better during this webinar and hearing what you've been through. So I'll turn it over to you now. Thank you so much.
So similarly to our other panelists, I have a child, my firstborn daughter, Eliana. She was born in 2013. And at the time, we live in Virginia, at the time, SCID was not part of newborn screening. So when she was born, she was healthy, everything was fine. Within 3 months, she started getting sick, and she had a chronic cough, she had loose stools, and there were other symptoms. And we were very concerned. Our pediatrician was concerned, and they sent us to Children's National in DC to try to figure out what was going on with her. And it was there that we met our immunologist, just coincidentally because of where we live. We live close to DC, and DC is a PIDTC center. And so the immunologist there was well-versed with SCID and was quickly able to determine that that's likely what she had, and later confirmed with genetic testing that she did have SCID, and she was about 3.5 months old when she was diagnosed. Thankfully, so she also had PCP pneumonia. She had some other things going on. She had rotavirus because at 2 months old, she received the live rotavirus vaccine. And when you have SCID, you have no immune system. And so she just ended up getting the virus. And luckily, with medicine, we were able to get rid of the pneumonia and the rotavirus, and she started her prophylactic medication. And then we went on to do gene therapy for ADA SCID with Dr. Cohn at UCLA. Bone marrow transplant was an option. However, she had, I believe, 2 potential donors. However, her physician was not thrilled with them because of their age and other factors with them. There's also a greater risk of GVHD when you have a bone marrow transplant. And so because gene therapy was available, we decided to go with that. And we're very happy we did. She's doing very well now. She's 8 years old, finishing 2nd grade, has a lot of attitude, and I love all of it. And so when she was, after gene therapy, my husband and I wanted to have another child. And personally, I would have had another child naturally because I thought she was so amazing. I would do everything again, if I had to. I didn't want to have another SCID child because who wants their child to have to go through, all the really negative things that happen when you're ill and going through transplant. I was happy to adopt. I just wanted her to have a sibling. I wanted to have more children. My husband, though, said, if we have another child, who knows if she is going to be as lucky as Eliana is, if they do end up having SCID. ADA SCID affects both boys and girls. It's a recessive gene. Both my husband and I are carriers. So the microsort wouldn't really have helped us. And we knew some families that had gone through IVF and PGD, and had done that specifically to have a sibling that was also an HLA match. Now, since Eliana had gone through gene therapy, she was already post transplant. However, because it was still in clinical trials at that time, we didn't really know how long is this transplant going to last? What does the future look like? So similarly with the Harrises, we decided, if we go through this IVF PGD, we could also do HLA testing. And if we're lucky enough, perhaps she'll have not only a sibling, but a sibling that is also an HLA match. And we were very lucky in that sense. We did our first round. We had 6 embryos. 2 of them had SCID. 4 of them were all carriers, but did not have SCID. So of the 4 embryos that did not have SCID, 3 of them actually ended up being HLA matches. And so we implanted one of them, and that's where my son comes in. And so he was born when Eliana was 2.5 years old. And it was such a relief knowing the whole time that I was pregnant that he is going to be fine, that I don't have to worry about, going through transplant. I don't have to worry about him getting a cold and complications from that. Is he going to survive or not? I had a pregnancy knowing that I was going to have a healthy child. So I was so happy for him. And I was so happy for Eliana because we were able to bank his cord blood. If she needs to have a transplant in the future, she has a perfect sibling match. She can use the cord blood. We could tap him for more bone marrow cells if need be. So that was basically our journey. And they're both doing very well now. And I will say that in terms of cost, this was in 2015 when we did the IVF and PGD. And it was about 28,000 American dollars. And I had never done IVF just for fertility reasons, but we had spoken to some of the people at the IVF center, and for comparisons, they told us that if you're just going to do IVF for fertility reasons without the PGD, it would be closer to $20,000 or so, if I'm remembering this correctly. Again, this was in 2015, so I'm sure the prices have changed. And we still have our embryos, and we pay about $600 a year to store them. We have not ruled out having another child. I'm 34, and so if my husband decides to have another child, I hope he hurries up. But it's certainly an option for us. And I don't know what we will do once I get past childbearing age, what we will do with the embryos. That's on the back burner. It's not something that we're thinking about right now. So for now, we continue to store them. And I think that's about it.
Well, thank you so much, Caroline. And again, we're hearing that word relief. It sounds like it was a relief to you to know that that you were going to have a happy child. That's something that a lot of women just sort of take for granted. I believe they just don't think that, this is, certainly I didn't, when I got the diagnosis that anything was going to happen until it happened. And so, but we in our community know once that diagnosis comes, and you were able to make decisions that that now I can see the smile, and you seem like a very relieved person, that you made a decision that was right for you. And now you have 2 beautiful children. Yes. And a question for you regarding the rounds of IVF and PGD, was that something that you felt was like a long experience, or did you feel like it happened in a pretty, straightforward fashion?
Yeah, I don't know if it's because I was just so focused on my daughter recovering from gene therapy at the time that we were doing IVF, but it wasn't a particularly long process. So for us, it took about, from start to finish, it took about 3 months, which seems very fast. Right. I will say this though, the IVF center we worked with said that typically what takes the longest amount of time is the lab that they work with. They have to take our DNA, my husband's and mine, and they have to, I guess, isolate this gene. So they have to see what the ADA gene looks like in us, the ADA SCID, which causes the ADA gene that causes the ADA SCID. So they have to take that gene, and then once they know what it looks like and what they're working with, once we have embryos, they can test the embryos and see which embryos are carriers or affected, or neither carrier nor affected. And because we started that way earlier, before we even were ready to implant, we just started the process with the lab, and that took a few months too. And so I can see it maybe taking 5 or 6 months from start to finish, but for us, we did the lab earlier, and then later on, once we were ready to start IVF and, you know, doing all the drugs and fertilization, everything, that took about 3 months.
Thank you for walking me through that. The process can seem a little bit overwhelming. When I looked into it, dipped my toe in that water, thinking about having a savior child for my son, I remember just, wow, just feeling like, how, you know, can I manage all of this? So thank you so much for giving us like a step-by-step, and just your calm and your way of speaking really makes me feel so comfortable thinking about it. If this were something, yes, I wish I knew you way back when, Carolyn, because there's so few people I know who've gone through this. So
yeah,
this is so valuable. We are so pleased to welcome Dr. Andres Rigg. He's going to talk about his expertise and also comment on what our panelists have gone through, and answer questions if anyone would like to ask additional questions. We see some questions in the chat as well, so he'll be able to go over those. Dr. Rigg is a specialist who joined a Jefferson RMA Fellowship Program in 2021. He was born and raised in Valencia, Spain, and he's a graduate of the Medical University of Lodz, Poland. He went on to take a position as a postdoctoral fellow at Yale School of Medicine, where he completed his OBGYN training. And he was the recipient of the Excellence in Resident Research Award in 2019 and 2020. He has authored several peer-reviewed articles in reproductive issues. And Dr. Rigg, we could not be more thrilled to have you here to join us today to help us learn more and answer some questions about family planning and PI. And so I'm very pleased to turn it over to you.
Thank you. I'm a fellow. A one-liner would have sufficed. But no problem. Not unlike Cindy and Rob. I don't live in Australia. I live in New Jersey. But I was on call all night, and I started working at 6 a.m. this morning seeing patients. So I am also a little off. If I hiccup a little bit, just let me know, and I'll rephrase whatever. Thank you so much for inviting me. Let me just share my screen here so we can get started here. All right, perfect. I hope you can see my screen. So essentially, the main goal of me being here, I think, why you guys invited me, was to talk a little bit about sort of what can the fertility world, which is where I'm at, have to offer to the world of inborn errors of immunity, particularly these 4 diseases that you all represent through your organizations, but in general to this community at large. First of all, thank you so much for inviting me. I'm most importantly just learning a lot from all of you and from listening to your stories. So thank you for sharing. I'm, like I said, a fellow at EBRMA New Jersey, which is a fertility company here in New Jersey. But I also am the husband of an immunologist, pediatric immunologist, and who trained at the University of South Florida. She now works here in New Jersey as well. And so I've had the luxury of having her give me some background on all these things that you guys know a lot more than I do about. So we'll get started. Let's see if this works. There we go. So first of all, we'll frame this whole talk on, like we said, on these 4 conditions, but they sort of serve as a proxy to speak about all the other conditions that are similar, in the sense that most of these are X-linked. Again, not all of them, like for example, SCID or some forms of CGD, but it'll serve as a good jumping board to speak about X-linked inheritance and how PGD and that type of thing can help there. And then what is perhaps much more important than the fact that they're X-linked or recessive or all that from the IVF and PGD world is that they're monogenic. And so we can test for that specific gene in an embryo, and we'll get more into that. But that is perhaps the key element, right? That things like CGD, SCID are caused by a particular gene, WAS, hyper-IgM, all of them, that can be tested for. And so that's sort of the key element here. Now, In terms of what we can offer, I like to sort of divide it into three approaches. You have talked about two of them a little bit so far. There's another one that is this first one here, and that's the fertility preservation. This diagram is something I made a long time ago, and it's intended to mean protecting an ovary from chemotherapy, but it's applicable to testicles as well. The main idea here is that, of course, there is the concept that whenever we do, say, for example, things like chemotherapy or radiation, things like that for conditioning for bone marrow transplants, those can be toxic to gonads, right, to ovaries and to testicles. And so we'll talk a little bit about what can be done in that sense. Another approach that you've talked about is the idea of doing what so far we've called PGD. I'll call it PGTM, but we'll talk about that later. But essentially is the idea that we want to have a child that is not affected, right? And then finally, the other idea is that idea that Rob and Cindy and Carolyn introduced, which is the idea of basically having a sibling match that could help an already affected child. So we'll talk through all of these in a little bit more detail. The first one sort of entails sperm or egg freezing, some sort of gamete, sperm or egg, doesn't really matter, depending on who you are. Freezing before we do the chemotherapy or the radiation. We'll speak about that a little bit more in depth. The second one involves genetic testing, like the PGTM or PGD that we've spoken about. And the last one involves HLA testing of embryos so that we know that there will be a matched sibling. Now, before we go a little more in depth into this, I just want to talk about some considerations about all of this, right? And there's several things here that we should talk about that are important, right? Number one, we'll talk about ethics, and we've spoken a little bit about the idea of having remaining embryos that are then stored and what to do with them. There's also the idea of IVF itself, that we'll have to go through IVF itself in order to do most of these things. And there's finally the idea that, you know, we may not, I've heard the argument before, this was actually hotly debated in my country in Spain when I was a teenager, 20-year-old. And the idea of matched sibling, of IVF to achieve a matched sibling was starting. There was a lot of debate. Spain is a very Catholic country. And so there was a lot of ethics and beliefs debates and debates sort of between the IVF world and the church world about the very idea of having a baby for this purpose, right? Like, is that right? And the reality is that it's right or not, depending on who you are and then on what you believe in. I would argue that, you know, having a baby so that the first baby has somebody to play with is equally a valid reason, right? So I think this is basically up for debate, and it's something for every person to consider. The other aspect of it, importantly, is the economic aspect and the access of care, the access to care aspect. And so, like it's been mentioned already, granted, there's options to do things like fundraising. If you have some amazing community like Rob and Cindy do, or you may have the money to do it, or you may live in a state where insurance is mandated and may or may not cover this, depending on what insurance you have. There's also other organizations that we can talk about. But the reality is that this is an expensive process, and generally speaking, that means that that economics can sometimes be a barrier to people. And then the other part of it is access to care, right? There's fertility clinics kind of everywhere in the U.S., but the truth is that most places in the Midwest and in many places in the southern country, access to IVF is relatively limited. And the nearest clinic may be far away, or it may not be a clinic you like, or whatever. So all of those things are important things to take into consideration. Just to sort of preface all of this by saying this is not necessarily for everyone, but I do want to have essentially an open conversation where anybody can ask any questions and where we can kind of learn from each other is the main idea. So we'll talk about the first of those three things that we spoke about before, fertility preservation. The situation here is basically, like we said before, right, that conditioning for stem cell transplant carries a high risk of infertility. The truth is that the agents used, the chemotherapy agents used, I don't know which ones have been used in your children, for example, but especially alkylating agents, for example, busulfan, which is very commonly used for this, or cyclophosphamide, which is more commonly used in cancer, but can sometimes be used for this as well, are alkylating agents. And what that means is that basically they affect the DNA of rapidly dividing cells. That's how they work. And so some of the most rapidly dividing cells in the body are the cells that surround eggs in the ovary and the cells that make sperm in the men. That's a little different, how those are produced in men and women. But essentially, suffice it to say for now that essentially when we give chemotherapy and or radiation, depending on the type of radiation, it can affect our ability to produce more sperm and more eggs. And so the question is, what can we do about that? Now, the solution for that is to freeze sperm. I'm talking about sperm because generally speaking, we assume that X-linked conditions will be more prevalent in boys, but this applies exactly the same to eggs and to women. And so what we do is we obtain sperm, we freeze sperm before the treatment happens. Then we do the treatment, the bone marrow conditioning, the conditioning for the transplant, the bone marrow transplant, or stem cell transplant. And then when needed, if this patient has been rendered infertile by the treatment, then we can consider doing IVF with those frozen gametes. And we'll talk a little bit about what that entails in a little bit. The important consideration for this is that, like you've been describing in all of your stories, the vast majority, if not all, of people treated with a stem cell transplant for things like, say, CGD or Wiskett-Aldrich or hyper-IgM or SCID are, generally speaking, very young children. And so there's a big difference between the ability to do this pre-puberty, meaning before starting puberty is what I'm trying to say, and post-puberty. So reproductively speaking, biologically speaking, the reality is that we are not equally able to produce sperm and eggs before and after puberty, right? Once we hit puberty, for example, in women, and we start having cycles of menstruation, that means we're ovulating. And what that means is at this point, we're making eggs that can be useful. Before then, there's no way. Same goes for men. It happens a little earlier in men, but it's a very similar story. The reality is that we don't start producing sperm until we hit puberty, at least not mature, good quality sperm. Now, post-puberty, this is a no-brainer. It's easy to get both eggs and sperm, relatively straightforward, not a particular challenge. Pre-puberty, there are experimental techniques, especially this has been developed more so than in the area that you guys are covering or that you guys are interested in, more so in the cancer world. And so for things like early childhood cancer, things like that, who also need to receive chemotherapy at young ages, there's been some studies that essentially what they do is take a small aspiration of the actual testicle, a little biopsy of the testicle essentially, or a little biopsy of the ovaries. And then from those tissues, they're eventually able to get eggs and sperm out when they need them. This is absolutely experimental. Some places in the US do it, but it is currently deemed experimental. There's the science is ongoing, very, very promising, but currently for the pre-puberty world, somewhat limited. And so this is something that is interesting, but that may develop in the future more towards it becomes an interesting thing for this particular area. The next areas where we're going to spend a little bit more time is the idea of doing PGD or genetic testing. And we'll talk a little bit about sort of mode of inheritance, the need for IVF. And because I know that the actual IVF process itself, that has nothing to do with the genetics of it, but that is necessary for this, is also kind of new to many people. I'll just go over sort of briefly the IVF process so that you're all aware of this. So the goal here is, of course, we want to avoid having a child with a genetic condition, right? We know we're a carrier. We want to make sure we have a child that's not affected. And so there's a number of options for this. First of all, like we said, to use genetic testing in order to have a child free of a disease, we need something to test, right? We need to test some embryos. So this is a blastocyst, which is a day 5, roughly, day 5 embryo. So we'll kind of follow this blastocyst throughout its sort of short life cycle until it's transferred. And the way we get to the blastocyst is through IVF. So we'll do a very quick overview of the IVF process. Essentially, this requires ovarian stimulation, which, on the woman's side, obviously, which is basically injectable medication to get an ovary to produce not one egg like it normally would every cycle when you menstruate, but instead of producing one mature egg, to produce as many as that ovary will give us that particular month. Now, these are from the ones that sort of are selected that month already. So it's not like you're depleting your reserve or you're not, going to go into menopause earlier or anything like that. But it is important to understand that this is a treatment that, like, for example, the example that Caroline said in terms of time frame is sort of the most ideal situation, right? So virus stimulation takes about 2 weeks. And after those 2 weeks, we do an egg retrieval, which is done through ultrasound. It's done vaginally through a needle, under anesthesia, of course. And then once we get those eggs, what we do is we make embryos with them and with the sperm of the partner or donor sperm. And once we do that, then we grow those. And we'll go a little bit more into this particular sort of third box here in just a second. Then we get the test results of those biopsies, like they were describing earlier, for example, Rob and Cindy and Caroline, where you get results saying, for example, this one is affected, or this one isn't, or this one is a carrier, or this one is a carrier, but it's not an HLA match, for example, if that's what we're looking for. And then in a completely separate cycle, this all happens. It may take a couple months. And then after that, we do a cycle where we're basically just getting ready to put that embryo back, to do that embryo transfer. And so we do an endometrial preparation cycle, which is usually just oral pills and some progesterone. And then once the lining is ready, we thaw the embryo, and then we do an embryo transfer. In terms of how the actual process works, once we've obtained the eggs is this big yellow and white cell here. We get basically one of those eggs from the woman, ideally more than one, of course. And then we place them together with sperm until one sperm goes into the egg. This can also be done manually through something called ICSI, where you sort of inject this classic sort of, IVF picture where the egg is being put into the egg. So it's very similar to that. Once we see that, we wait to see how many of those eggs that we put sperm in fertilized. After about 3 days, they've divided and form about an 8-cell embryo. And then after about 5-6 days, they form this sort of 200-cell spherical structure called a blastocyst, which is the one we were talking about a little while ago. This is actually where we test. Now, some fertility clinics do things like, for example, day 3 embryo transfers, which is this previous one on the left side of your screen. These can also be biopsied for things like genetic testing. It's a little bit less safe and less accurate. So generally speaking, most places nowadays do blastocyst transfers, which is the orange one on the right. And we also do the biopsy at this stage too. So essentially we've gotten the egg, we've put the sperm in, we've let it fertilize and grow for 5 days. And like Rob and Cindy's experience, not all of them will make it, right? So you can have a bunch of eggs. Of those, some eggs will be mature, some will fertilize, some will make it all the way to day 5, and those we will biopsy. This is what the biopsy looks like. I'm gonna try to play this video for you if it works. Let's see. This is a video from our own clinic. But basically, this is a blastocyst on the left here being held by a pipette under the microscope. And what they're doing is basically just with that little pipette and the laser, which is the blue circle, a few of the cells that will eventually become the placenta, importantly, not the ones that will become the baby, just the placenta, are basically just separated from the embryo and taken up by aspiration. And that way is how we can do the biopsy and make sure that we know what the genetic makeup of that embryo is. The embryos after the biopsy, so they've grown to 5 days, we biopsy them and they're vitrified in liquid nitrogen at minus 196 degrees. And we wait for the results of the biopsy, which usually takes anywhere from 2 to 4 weeks approximately. Because we need to wait for those results, we need to have what we call a deferred embryo transfer, right? Meaning we'll need to freeze these eggs, and while we wait for the results, these embryos, and then we'll need to do an embryo transfer. We can't just do it right then and there in that same cycle because we need some time to get those results back. These frozen deferred embryo transfers have better outcomes anyway. That fresh transfers has been very, very well established in the IVF world. So it's actually not a hindrance. It's just kind of a matter of time. In terms of how these are inherited, I have no intention of explaining to you how an X-linked disease is inherited, because you probably know it inside and out by now. But essentially, just to give a very, very brief overview, as we all know, women have 2 X chromosomes and men have an X and a Y. So X-linked diseases are those that are affected by, they're caused by mutation in a gene that is on an X chromosome. So what this means is that a carrier woman will have 1 X chromosome that's fine and 1 X chromosome that's not. And an unaffected male, for example, will have an X chromosome that is fine and a Y that is obviously fine because it has nothing to do with this whole thing. An alternative possibility for a couple is that the woman is perfectly fine, she's not a carrier, and the male is a carrier. and therefore affected because there's no normal copies, because there's no normal X chromosomes there. So this is important in terms of the match. We kind of, can have this first couple here, whom has some options depending on what they're doing, meaning if the woman is affected. And then there's this couple here in which the male is the affected one, or sorry, in the case of the woman, it was a carrier, not necessarily affected. In the case of the second couple, the male is the one that's affected and the woman is not a carrier. Now, of course, it is possible that they are both affected, right? That the male, is affected and that the female is a carrier. Extremely rare, we will have a female with both affected X chromosomes. Technically possible, but extremely beyond rare. So we'll talk a little bit sort of about the options that these people have depending on, excuse me, on who they are. So possible solutions. Let's say you're a girl and you're the one who's a carrier. And so one option you have is to have a girl, right? And she may be a carrier. She'll have a 50-50 shot of being a carrier, depending on which X chromosome you transmit. And we don't have to worry about the fact that she's a carrier, although we know that then she'll have the chance of, for example, say, having the child that's affected in the future, or things like that. There's also, if you're a boy and you're the one who's affected, then you could have either. And don't worry about the fact that you'll have female carriers, and there's pretty much no way you'll have an affected boy, and there's pretty much a guaranteed chance that you'll have a carrier female. But if you're not worried about the carrier status, then that's not a problem. Now, in some diseases, the carrier status is interesting, and this is an active area of research, so I'll just kind of put it out there. But as you all know, there's a process called lyonization by which a female who is a carrier, essentially in females, the X chromosome, you have two of them, every cell essentially chooses one random X chromosome out of the two to make proteins out of, to use. And so one of them is inactivated and the other one is active. And this is completely random. So approximately 50% of your cells will have the right active one and 50% of them won't. And so generally speaking, there's sort of a positive selective pressure by which the healthy ones are the ones that survive the most, therefore reproduce the most, and therefore we have more cells that are fine. Now, in some cases, it happens sort of the other way around because, like we said, it is by chance. And so it can happen that female carriers, through inactivation of the right chromosome, may end up having symptoms of CGD, for example, and actually be affected. So the carrier status is not entirely irrelevant. It's just a little bit more of a sort of newer area. So one option in order to sort of choose whether we have a boy or a girl is we do IVF and sex selection, right? And this can be done through a number of ways. The most common one today in the US, the easy one, is PGTA, which is basically pregestational testing for aneuploidy, which is why the PGTA and the PGTM. PGTA is for aneuploidy, which just basically means to make sure that the baby has the right number of chromosomes. So we want to make sure the embryo doesn't have things like Down syndrome and things like that. But incidentally, one of the things we find out is how many X and Y chromosomes we have, so we know if they're boys or girls. Microsort, which we've spoken about before, I can answer questions on that later if you guys want. But like we said, it's currently not FDA approved and not available in the US. So we can talk about that more if you wanted to. But those are basically options for sex selection. The other part of it is the other alternative is to do IVF and test for the actual disease through what you guys have called PGD and what is currently called PGTM. So it's basically pregestational testing for monogenic disorders, which is specifically looking for that particular disease. In terms of what this genetic testing entails, this is the first IVF baby, Louise Brown. She was born in 1978. And since then, we've kind of been really keen on choosing the right embryo. This is one of the first attempts at that genetic testing. This was called FISH, fluorescent in situ hybridization. And essentially, it was able to tag an abnormal gene in a chromosome and be able to just sort of tag it so that we would know which embryo was affected. In terms of these two methods, the idea is that PGTA is routinely offered pretty much everywhere in the IVF world. It screens, like we said, for aneuploid embryos, and it's the most widespread version, right? This is very common. Now, PGTM is a little different. It tests for a specific gene variant. We do this in your cases, for example, when we already know it's there. And also in anybody undergoing IVF for, say, fertility reasons, we do carrier screening on both mom and dad so that we know if they happen to be a carrier for the same thing unknowingly and then transmit it, for example, like in the case of Carolyn. So this essentially helps with avoiding disease transmission or predisposition. And it's perfect for single gene disorders like these disorders that we're talking about, for monogenic disorders. What we do is basically, let's say you are this person who is a carrier or is affected and wants to have a child that is unaffected. So first we do basically genetic testing on the parents. We try to identify what is being tested for. And we do this through basically looking at a particular sequence in the chromosome where we see that there's the affected gene. We get samples from the prospective parents, and we get samples from close relatives, ideally, because they have the closest DNA in general. And that way, if they are unaffected, we can compare where the mutations are. Depending on whether this is a dominantly inherited gene, a recessive inherited gene, or an X-linked inherited disorder, we need different types of samples from the parents, and we can go into that in more depth if you wanted to. But essentially, suffice it to say for now that we do need samples from the parents to be able to create the probes for that. We're essentially creating a specific probe for that particular mutation that you are carrying. Now, these are different methods of doing this. Just to say that in case you hear about them, target amplification, whole genome amplification, NGS, which is next generation sequencing. Today, most places will use the one on the far right here, the NGS. This is the most sort of fast and cost-effective and thorough at the same time. So basically, the technology has sort of evolved sort of from left to right on the screen here. These tests need to be validated for every single new variant and being investigated. So if you have a variant that has been described before, great. If this is, let's say, a new variant of some same disease that is new, that hasn't been identified before, but causes the same disease, for example, then it will need to be investigated again. We only have a few cells because the embryo is relatively limited. It's not like a blood draw where we have millions of cells. And so we usually, what we do is we test that, then we do the test, and then we run the tests on donated embryos from previous people, say abnormal embryos from the past, things like that, or on other cell lines, sometimes on cell lines that have been established from the parents. And this is really, really accurate. It's over 99% accurate. The chances of having an embryo that was marked normal actually have the mutation is actually less than 1%. This is a very busy slide, which I won't go into too in depth, but the key thing here is just important considerations. Carolyn and Rob and Cindy have talked about this a little bit. The main key thing here is that basically it may not work the first time. It is a game of chance. We are not making correct embryos. We are choosing the embryos that have correct genetic material out of all the ones that happen to be made. An older woman, for example, who makes less eggs is less likely to make a normal embryo because we'll have to look through those embryos. And also, when we do PGTM, we also look at the number of chromosomes. So if the number of chromosomes is abnormal, but the mutation is not there, we still can't use that embryo. So the more layers we add to it, the harder it becomes to find the embryo that meets all the criteria, of course. That's the main idea. And so, of course, this has those ethical and moral considerations that we spoke about earlier. The final aspect, and I'll just talk about this briefly. I think I'm going over time. I'm sorry. But basically, in the case of the matched sibling, which Rob and Cindy have explained better than I can, essentially the goal is to have an unaffected child, number one, that is also a matched donor sibling for a child that is already affected. This is what is currently called PGT-HLA, and HLA just being the regions in the DNA and the proteins that actually determine the quality of the match and the degree of the match. And I just want to touch upon this very briefly, but the important thing here is that PGT-HLA, like Rob and Cindy and like Carolyn did, should always be performed in combination with PGTM, right? We don't want a kid that is a match that is also affected. So we should also do both things to avoid transmission. And then it's exactly the same idea as the whole PGTM, so I won't go into it in depth, but just basically to make it clear that it's the same idea with there's basically a game of chance. We're trying to make as many embryos as we can to test them and find one that is both a match and unaffected. In terms of other options, aside from all of this, we can just eliminate our genetic makeup from the mixture, right? It is possible to have a child without somebody's genetic makeup. The sort of most straightforward answer, although not straightforward at all to accomplish if you ask anybody who's done it before, is adoption, which can take a long time, but it's super rewarding and is a fantastic option on how to build a family. Another option is gamete donation, egg donation if the woman's affected, sperm donation if the male's affected. And lastly, embryo donation, like one of the stories we've heard earlier, when there are leftover embryos, not only from this process, but also from regular fertility process, from regular infertility IVF, there are leftover embryos that are perfectly fine. And so we could sort of adopt that embryo, which is what happens, and then we transfer that embryo into you, and you can carry that. And since it doesn't have genetic makeup, it won't be affected. In terms of future options, just a couple little things here. There is some research being done beyond experimental, super futuristic for now, which is the idea of potentially being able to do PGT without IVF, meaning without having to go through IVF to make the embryo, but just getting pregnant and knowing what's going on right away, not waiting until we do like a CVS or an amnio or things like that that are during pregnancy to test. Very futuristic. And finally, gene editing, like has been described before, already an option for some conditions. In the future, very likely an option for not only choosing the right embryos, but correcting the ones that are not right as well. For example, for Rob and Cindy, this would have been fantastic the first time around, right? You make some embryos, they're all affected, but can we edit them and correct them? And so this is super futuristic. There is a ton of moral and ethical considerations about this, but it is definitely something that is coming down the line, and there's no question that this will be a part of our lives in the next 10, 20 years. So with that, I'll end. Like I said, I'm sorry I went over time. I got a little more involved than I thought I would, but I'm happy to answer any questions and to participate in the conversation. Thanks again for having me, and again, I've just learned so incredibly much from all of you. Thank you. You're muted, Felicia, I think.
There I go again. Okay, thank you so much, Dr. Raig. That was a wonderful presentation, and we learned so much from you. So we are very grateful to you for your time and for giving us so much good information. And I believe there were some questions that were in the chat. I think that some of them have been answered. If anyone would like to ask any further questions, we can ask the doctor now in the remaining time that we have. Are there any further questions? And we also have some questions that came up that are from our community. And so we wanted to just ask you quickly about the potential for children who've gone through transplant to be fertile. That's something that's on the minds of a lot of parents these days, especially mine. So I wondered if you could give us some additional information about that. I know you talked about puberty, post-puberty. There's cryogenic freezing and things of that nature. But for parents who perhaps haven't had that done, we are hearing that there's a small percentage of children that go on to be adults and are able to have children naturally. So just wanted to see if you could comment on that and what you've heard. Perhaps there hasn't been a lot of data on this, but anecdotally.
No problem. So the main idea is, that everything's a game of chance, and biology is never 100% in any direction. That being said, the chemotherapeutic agents used for conditioning, especially if used in combination with radiation, but even by themselves, have a very high likelihood of rendering somebody infertile. This is not a given, and in particular in men. So women, much less likely. Women are more likely to be infertile, period, after this. Men are much more likely to produce more sperm because men produce sperm throughout their life as opposed to women who are born with a set number of eggs. And so as men sort of use the cohort that was killed off by the chemotherapy, a new cohort of sperm will come in, assuming the original stem cells producing those sperm are not affected. Very likely that they are, and therefore they'll either be a little subfertile, so to speak, or straight up infertile. It is possible that some of them may go on to have children, but I think if given the option, if it became a little bit less experimental than it is now, preserving those sperm before we undergo treatment, I think would be a wise decision just from that perspective. That is, it's basically a good insurance policy against something that is almost guaranteed to happen. The other important consideration to have, and this has nothing to do with the ability to have children in the future, but is the fact that regardless of having had a bone marrow transplant, those stem cells that are making new sperm still have your original genetic makeup. And so most likely, save some particular situations, but in general, the sperm may still transmit the affected gene. And so this is something important to consider for the future.
Right, and that is another question that we had that came up. We're going to have to conclude. This has been so interesting. We have a few seconds left, and we have the names of people who enter their name into the raffle. We'll be sending you out the wellness gifts after this webinar. I wanted to thank everyone for joining us, Dr. Rieg, all of our panelists. I wish all of you a very happy Mother's Day tomorrow. And I'm so grateful that we had this special time together. We all learned a lot, and to hear everyone's experiences has been so rewarding. Have a wonderful day, everyone. And I hope we can all do this together soon. If anyone has any questions for Dr. Rieg, he had his email address as well there, and you can always reach all of us after this call. I think that is everything. Happy Mother's Day, everyone. It's now 12:30. I hope you enjoy the rest of your weekend, and I look forward to seeing you again soon. Thank you all.
Bye, everyone. Happy Mother's Day.